We're going to wait a couple minutes. Hello, everyone. We're going to wait a couple minutes, see if anybody else is joining. Well, we're just waiting a couple minutes to see if more people will join. We'll give them a couple more minutes and then we'll get started. Hello, everyone. Welcome to another one of HeartBrothers heart failure awareness webinars. Thank you for attending. Today's subject is going to be heart failure comorbidities. I'm Hamid Madavi, and I'm a heart transplant recipient and the member of HeartBrothers. Actually, today is my 7th-year anniversary of my heart transplant. So it's a good day.
Today is?
Yes, it is.
Congratulations.
Thank you. So here we go. Okay, so
Should I go ahead and start?
so let me go ahead and start. So next one is, so I just wanted to cover a couple of the Zoom best practices. Maximize your screen size. For comments and feedback, please put it in chat. We'll be monitoring the chat, and for questions, please put them in the Q&A session. A quick introduction of HeartBrothers. HeartBrothers was founded by two gentlemen, Patrick Sullivan and Bob Romer. They spent a year of their life waiting for a heart transplant, and while they were there, they made a commitment that if they ever got out alive, they would do something to give back to the community. So they started HeartBrothers. We have about 70 ambassadors. We'll get to that shortly. But we know a lot about heart failure as patients, and hopefully we can share our knowledge combined with the knowledge of some of the best physicians in Boston to help you guys navigate your journey of heart failure. So we, the team HeartBrothers, we're patients, just like you. We're traveling the heart failure journey, and all of us after a transplant, we've decided to give back to the heart failure community. The mission of HeartBrothers is to help and support heart failure patients and their loved ones navigate a life with heart failure and all its challenges. Our programs are Heart of Survival. We provide gap assistance and tools for patients and families to help them survive long-term hospitalization. Team HeartBrothers, we have about volunteers, we call them ambassadors, that they're transplant survivors, and we provide face-to-face interaction with patients and families. We do bedside visits at hospitals, we take phone calls, do Zoom meetings, one-on-one, to help patients and their families, just share the experience of peer-to-peer to help them answer questions. We have HeartBrothers House. It's 2 downtown Boston apartments. We provide short-term housing option for heart failure patients. It's pretty much walking distance to all the hospitals in Boston, and it is available on a first-come, first-served basis. You can go to our website to get more information about it. We have a patient support group. We have a monthly virtual patient support group. Sometimes we'll have guest speakers, but besides that, we're just sharing information and knowledge and insight. And it's the second Thursday of every month at 6 p.m. We have the heart failure blog. We bring those in the heart failure community together with up-to-date heart failure news. And we support New England Donor Services with organ donation, and we do a couple of joint programs. And it's just them. So a quick rundown of our events. We have monthly patient support group. We have an annual symposium for 2023. It's going to be November 29th through December 1st. And we have a heart failure awareness 5K run walk. We had one this year. And for 2024, as you can see, we're going to have that as well. So for 2024, we're still going to contain the virtual patient support group. We're going to have probably 3 to 4 webinars in the spring and 2 to 3 in the fall based on interested topics and just what are the current issues, new equipment, new devices, new treatments. We try to bring that to the patient community as soon as they're available. I know of 1 or 2 that were already in the planning that are going to be very exciting, talking about some new medical equipment that will significantly help heart failure patients out. We will have our heart failure awareness 5K run walk. That will be typically in May. And we'll have, again, our symposium next year around end of November, beginning of December. The event sponsors are Novartis Corporation, they're sponsoring this particular webinar, and Transmedics, which is a HeartBrothers corporate sponsor. I thank them both for their support. I just wanted to share a little bit of advice that, we offer some great medical advice from some top physicians, but this is, again, just advice based on some general information. Please, please, please consult your own physicians or treatment center regarding what works for you and what you should do as a best strategy for your treatment. Do not change your treatment regimen based on information we provide here. And please stay in touch with us. You can contact us at HeartBrothers Foundation on Facebook. We have a Facebook page, we have an Instagram page, and we have a LinkedIn page. Thank you very much and have a great day. We are going to turn it over to Joy once I figure out how to use my computer.
That's all right. I can do mine without the slides. Okay. Hello, I'm Joy Donohue, longstanding HeartBrothers volunteer, and it's a pleasure to be here this evening to host tonight's webinar highlighting heart failure comorbidities. This evening, we're very fortunate to have an expert on the subject. It's my great pleasure to introduce Dr. Lana Tsao, the Assistant Director of Heart Transplantation at Mass General Brigham and Associate Professor of Medicine at Harvard University. Dr. Tsao trained in cardiovascular medicine at Mount Sinai Medical Center in New York, followed by an advanced heart failure and transplant cardiology fellowship at the New York Presbyterian Hospital of Columbia University Medical Center, and a cardiovascular research fellowship at Mass General Hospital. Dr. Tsao also established the Cardiac Transplantation and Mechanical Circulatory Assist program at UMass, developed the heart failure program at BIDMC, attended at Columbia Presbyterian Medical Center, and was the director of advanced heart failure at St. Elizabeth's Medical Center. So now I'm going to turn it over to Dr. Tsao, and you're going to present your slides. Are you ready?
I am. Thank you so much for asking me to speak. I'm really privileged. I'm trying to figure out how to share my slides.
Your lower nav?
Because usually they have the share screen. Oh, it moved. That's why. All right, here we go. Can you see my slides?
Now we can. Yes, we go. Thank you.
Okay. So today I've been tasked with speaking to you about heart failure comorbidities. And I want to say that it's really a privilege to speak to this group. The HeartBrothers have done so much for our patients. I love that you have a support group, the apartment availability, and all that you do for our patients by coming to visit them in the hospital. It's just invaluable. So thank you for everything you do. I'm trying to move my slides. They're not moving, so hang on. I guess I have to leave it up in PowerPoint. Is that what it is?
Cursor on the.
Here we go. It's starting to go now.
Okay.
So I have no disclosures to speak of. So the objectives of this talk to provide a very brief overview of heart failure, because I know everybody here already knows all about it. It's just to make sure we're all on the same page. I'll talk about the different comorbidities which contribute to the development and exacerbation of heart failure. And we'll talk about how to treat the comorbidities very briefly. So everybody knows what heart failure is. It's a clinical syndrome. It doesn't mean that you're going to die tomorrow or that your heart's going to stop beating. It's caused by a structural or functional cardiac abnormality. We corroborate the diagnosis by elevated NT-proBNP, and we look for objective evidence of pulmonary or systemic congestion. Patients with heart failure are generally classified into two groups: heart failure with reduced ejection fraction, or systolic heart failure with ejection fractions less than 40%, or preserved ejection fraction, or diastolic heart failure, although it's not really synonymous, but we don't have to get into that. And that's patients with ejection fractions of over 50%. So ejection fraction is just the amount of blood that's ejected every time the heart beats. And normal ranges between 50 to 75. And then we have the mid-range or mildly reduced ejection fractions of between 40 and 49, and you could have had a low EF that's improved. So we categorize those patients in that group too as have heart failure with improved EF. We stage people through stages of A, B, C, and D, and those patients are at risk for developing heart failure, and they have risk factors, but they don't have heart failure. Stage B patients, they have a heart problem, but they still don't have heart failure. And the majority of patients that I see are stage C patients, meaning they have had episodes of heart failure or in heart failure, meaning they are congested or short of breath. And then we're not going to talk about advanced heart failure, but those are patients who require special interventions like Hamid did. We categorize patients also by their NYJ class, which is how functional they are. And class 1 patients are asymptomatic. Then we move to class 4, where they become symptomatic at rest. At this time, there are 4 pillars of heart failure management, and with 4 drugs: Entresto, Coreg or metoprolol, spironolactone or eplerenone, and Jardiance or Farxiga. And these are all evidence medical-based therapies which have been shown to improve survival. So that leads us to the heart failure comorbidities. And so we all start with the same background of what heart failure is and how to treat it. So the first comorbidity I want to talk about is high blood pressure. High blood pressure and coronary artery disease are the 2 most important contributors to the development of heart failure. So what happens with high blood pressure is that it's actually quite prevalent, and it's the leading cause of morbidity and mortality actually worldwide. And I've already said that it causes heart failure, but what happens with high blood pressure is you get thickening of the heart muscle, and therefore, and you can also have thickening of the blood vessels. So these patients who have thickening of their vessels, they are a 6-fold higher risk for developing heart attacks. They also have increased risk of atrial and ventricular arrhythmias, as well as stroke, and they have increased risk of heart failure. It's been shown that if you try to control blood pressure, that you can actually reduce the risk of patients moving from stage A to B or C heart failure. So just to show you what we consider high blood pressure now, it used to be that high blood pressure was considered to be greater than 140/90. So I don't know how everyone on this talk thinks of heart failure, of high blood pressure, but the definition of high blood pressure has changed in the past 6 years. Now we consider normal blood pressure as less than 120/80. And if you're elevated, it's 120 to 129/80, although we tolerate patients having blood pressures of up to 130/80. But then we start having patients over 130/80, we want to start to treat patients. And the medications that we talked about very quickly for heart failure, Entresto, Coreg, eplerenone, spironolactone, all of those medications which improve heart function also improve blood pressure. So you're kind of getting a 2-for-1. But it is one of the leading causes of cardiovascular death stroke, and cause of heart failure. So it's really important to control high blood pressure. Another major comorbidity in heart failure is diabetes. So the prevalence of diabetes in heart failure is about 20 to 50%, and diabetes may increase mortality due to heart failure. The two, diabetes and heart failure, kind of independently increase the risk of getting the other, and they both often occur together. For diabetic patients, about 70% of them show signs of loss of heart function within 5 years of their diagnosis, and up to half of patients with diabetes develop heart failure. So you can see that it's a pretty concerning comorbidity, and in fact is deadly in other ways because diabetes can affect other organs. And as far as the heart, you can see that it causes not just heart failure, but it can cause heart attacks and strokes. So the patients with diabetes have a twofold risk of developing heart failure, either a heart failure with reduced ejection fraction or preserved ejection fraction. In and of itself, diabetes can also cause a diabetic cardiomyopathy. It doesn't just cause coronary artery disease, but it can cause diabetic cardiomyopathy. And it was used to coin, this term coins disease that's cardiomyopathy without any other cause but diabetes. How do we treat it? Well, I'm not really going into treatments of how to treat these comorbidities. I'm just going to explain to you what they are, but it's really important to follow up with your doctor about treatments. And oftentimes people can end up on insulin. But one interesting thing about one of the diabetic drugs, which is the SGLT2 inhibitors that I mentioned when I showed you the 4 pillars of heart failure management, is that this diabetic drug can be used to treat heart failure whether or not you have diabetes. So taking a step back with diabetes, we do want to control diabetes, although interestingly, it hasn't been shown that having a low glucose necessarily prevents you from developing heart failure, but it has been shown to decrease cardiovascular events. So going back to this SGLT2 inhibitor, which is a diabetic drug used to treat heart failure, patients who were tested on Jardiance or SGLT2 inhibitors when it first came out, they found that these patients with diabetes, and they were doing a test to see how they responded and whether SGLT2 inhibitors were beneficial, were found to have actually less heart failure hospitalization and less heart failure events. So they went on and did another major study where they looked at patients who had heart failure without diabetes, and they found that this diabetic drug actually reduced the incidence of heart failure hospitalizations. So this is why SGLT2 inhibitors are important in heart failure. But we're talking about comorbidities, and so whether or not you have diabetes, this drug will be of benefit. Another comorbidity that we see in a heart failure is sleep disordered breathing. And sleep disordered breathing can be either central or obstructive, and it is associated with increased morbidity and mortality. So there's 2 types. There's obstructive sleep apnea, and that's when you have obstruction of your airway, which you can see here. And how that is achieved is usually there's several ways. You know, people can have a thick neck and they can be jowly. So when they lie down, they sort of, their airway kind of collapses. Patients with heart failure can develop sleep apnea because when they lie flat, the fluid moves from their body into their neck. And so it kind of compresses that way. Central sleep apnea is a different kind of sleep apnea. That's when the neurostimulus is absent or reduced to the thoracic muscles. So that leads to pausing in your breathing without airway obstruction. So as you can see here, this is a CPAP machine, and I don't know if anyone's seen a CPAP machine before on this talk, but it's continuous positive airway pressure. And what it does is it blows air in to try to prevent this collapse and to prevent people from stopping breathing. However, a lot of patients have a difficult time tolerating it. So there's a new device out called the Inspire device, which is an upper airway stimulator. So it stimulates the tongue to keep it from collapsing and through hypoglossal nerve stimulation. It's implanted in the chest, and It's in use. It's been approved by the FDA, but I don't think a lot of people are using it yet because, as always, there's trouble with insurance companies. As for central sleep apnea, no one quite knows how to treat it. We've been using CPAP, but it is not clearly always of benefit. The next comorbidity that I want to talk about is obesity. So obesity not only contributes to development of heart failure, but it also can cause sleep disordered breathing that we just talked about, high blood pressure. It contributes to insulin resistance and the development of diabetes. And the majority of these patients can go on to develop heart failure. So obesity doesn't just cause these comorbidities, which then cause heart dysfunction. In and of itself, obesity can cause a cardiomyopathy and lead to problems. Oops, so I think I got my slides mixed up, but just to talk to you a little bit more about obesity, HFpEF has really been associated with obesity. You can see obesity in both HFrEF and HFpEF, but more than half the patients who have HFpEF are also obese. And so recently they've done a large clinical trial called the STEP-PEP trial, where they looked at trying to reduce weight and see if they can reduce the incidence of comorbidities and heart failure. And what they did was they studied patients who had a body mass index of greater than 30 or a body mass index of greater than 27 with one comorbidity of either sleep disordered breathing, high blood pressure, or diabetes. And they found that there was an improvement in quality of life and greater exercise tolerance by weight loss, but using this weight loss medication called semaglutide. So obesity is an important comorbidity in heart failure, but if we treat it, we can improve functional status, at least in HFpEF, but I suspect it will be the same in HFrEF. So I think I got my slides a little bit confused because I was going to be talking about atrial fibrillation. So atrial fibrillation is a major comorbidity in heart failure. It frequently coexists with heart failure, but it can also cause heart failure, and heart failure can also cause AFib. So what happens with AFib is when a patient has AFib, they have loss of contraction of the upper chambers of the heart. So that contributes to a low cardiac output. And so patients can develop heart failure. Another way that AFib can cause heart failure is that AFib can go very, very fast. And as you can see, the heart is beating quickly and irregularly. So when the heart is not beating in a coordinated fashion, it's almost like, you know, you've seen those cartoons where they, what is it, was it Wild E. Coyotes running on the treadmill and he like slides off the treadmill because he's out of control. Well, that's sort of what happens in AFib, I think, in heart failure. So patients start to retain fluid and they go into heart failure by that. And that's called a tachycardia-mediated cardiomyopathy. So that's just a fast heart rate. And so you go into heart failure that way. And so the way to treat that, though, is through a number of mechanisms. One, we talked that AFib is similar. Oh, I want to mention AFib also has similar risk factors to heart failure, which include the obesity, sleep disordered breathing, diabetes, and high blood pressure. So we'll talk about how we can treat AFib, but you can reduce the incidence of AFib through weight loss, through controlling your sleep disordered breathing. And then you can think about AFib ablation, and it showed by increasing your glycemic control, you can also reduce the incidence of AFib. So all of these things are related, like a Venn diagram. And then I told you I had mixed up my slides, but here is how we manage patients with AFib and heart failure. So we have our guideline-directed medical therapy with the 4 pillars of heart failure management, and we put patients on blood thinners because one of our concerns from AFib is stroke. So all patients with AFib need stroke prevention with anticoagulation. But then we think about treating AFib in two ways. One, through rhythm control, which means we try to keep you in a regular rhythm. And I mentioned very quickly ablation in my last slide, but we can also achieve that by putting patients on medication. However, some patients, we can't get them back into rhythm or out of AFib, so we try to do rate control. And we do rate control by putting you on medications to slow your heart rate down. And one of those medications is a beta blocker, which you saw was one of our 4 pillars of heart failure management with metoprolol or carvedilol. And that goes for both HFrEF and HFpEF. And if we cannot achieve rate control, then what we do is an AV node ablation. Now, what an AV node ablation is different from an AFib ablation. An AFib ablation is when we try to get rid of the AFib and get you back into a normal rhythm. An AV node ablation is we actually snip the wires that cause the top chamber of the heart where the AFib is coming from talking to the bottom chamber of the heart, and we have a pacemaker pacing for you instead. So then the next comorbidity that I want to talk about was anemia. So anemia is actually quite common in patients with heart failure. There's a multitude of causes for it. One is just purely a dilutional effect because patients can be fluid overloaded. Sometimes the medications can suppress the bone marrow from producing erythropoietin, which makes red cells. And then a chronic illness, which is what heart failure is, suppresses bone marrow production, and the end result is anemia. However, they've shown that if you treat the anemia by stimulating red cell growth, you actually don't improve outcomes, and you can actually worsen them. In addition to the anemia, though, some patients are iron deficient. Whether or not they have anemia, they can actually be iron deficient. And that can be an absolute iron deficiency because of malabsorption from their heart failure, or it could just be because they have a lack of absorption or effect in the liver. So what Dr. Lewis at MGH has done is he's done a lot of work on looking at iron deficiency in anemia and heart failure. And he's found that by giving IV iron that you can actually improve patients' quality of life. We haven't shown clearly that by giving IV iron that you can improve outcomes, but we have found that patients can feel better. And so this is the algorithm for how we give IV iron in heart failure. And that's something I want to be clear on, is that we have found that actually it's IV iron that helps patients with heart failure, not oral iron. And the reason is, as I showed you earlier in this slide, there may be an absorption problem. And so oral iron is not absorbed, so we give it intravenously. And also, the other mechanism of absorption here is just by lack of availability from the liver picking it up. So what we do is we just measure patients' ferritin and their iron saturations. And if they're low, we give them IV iron. And then we repeat the iron studies in 3 to 6 months, and we repeat it again. So usually once you've been repleted, we can just check patients' iron levels annually and replete as needed. One of the last comorbidities I'm going to talk about in heart failure is high cholesterol. And again, these algorithms are just to show you how we supplement or how we treat each comorbidity. But how does high cholesterol cause heart failure? It kind of indirectly causes heart failure because it promotes development of coronary disease. And some studies have shown that it affects heart function and the cardiac pacing of the heart. But really the exact mechanism of what it does in heart failure per se directly is unknown. And so this is just an algorithm of how we treat high cholesterol. And it's based on age. If you're over the age of 75 or under the age of 75, or if you've already had a heart attack, the targets are either an LDL of less than 70, which is a bad cholesterol, or a less than 100, depending on if you don't have coronary disease. If you can't tolerate a statin, then they're the injectable drugs, which we're not going to talk about. But this is really just to let you know that high cholesterol actually is a comorbidity, and we should consider treating it. So this is kind of a summary of the comorbidities in heart failure. I didn't go in depth on anything because I only have 20 minutes. We didn't talk about coronary artery disease because many patients have coronary artery disease and as a result have their heart failure. So it's sort of been taken care of. Patients who have heart failure often have chronic kidney disease, and it's something we juggle and monitor with blood work, as anybody here who has heart failure knows. The medications that we give to treat heart failure can actually contribute to chronic kidney disease as well. And then there's valvular heart disease. Now, valvular heart disease can cause heart failure, but heart failure can also cause valvular heart disease because as the heart enlarges, it can cause the valves to become leaky. So the comorbidities that we've discussed today are iron deficiency. We talked about obesity. We've talked about AFib. We've talked about high blood pressure. We mentioned coronary artery disease, which is ischemic heart disease. We haven't talked about liver dysfunction, but it only contributes a small amount to heart failure. Patients who have heart failure can become depressed, or depressed patients can have worsening heart failure. It's kind of a chicken or an egg thing because it becomes a vicious cycle when you have a chronic disease. We have not talked about COPD, but that is really, a lot of it's from smoking, which goes to coronary artery disease. We've mentioned sleep apnea. We've talked about diabetes and briefly mentioned high cholesterol. So what are our goals for the treatment of heart failure is to prolong life, reduce symptoms, return to a more active lifestyle, reduce hospitalization, and prevent disease progression. We do that by optimizing GDMT, managing comorbidities. I briefly mentioned preventing thromboembolic complications and AFib. The management of heart failure really involves a lot of lifestyle modification, which means if you're smoking or drinking, you need to stop. And those are also, they're not comorbidities, but they can contribute to heart failure. So definitely part of our lifestyle modification. We've already talked about weight reduction and controlling all of our comorbidities or risk factors really for heart failure. We didn't talk about maintaining a fluid balance, but that's really important. I'm sure everybody's heard about decreasing sodium intake to less than 2 grams a day. And we monitor our weight, which is a reflection of fluid, which we can see when we have heart failure. It's really important to improve your physical conditioning because I tell everyone your heart is like a muscle. It is not like a muscle, it is a muscle. So we need to walk and not limit our activity. So, you know, I always tell people no pain, no gain. They'll tell me I ache, I hurt. And I say, well, you ache and hurt if you don't do anything. So you ache and hurt when you do something. It's better to do something. For selected patients, we need to control the ventricular response in patients with AFib, and we already talked about that, and I showed you the algorithm. We didn't talk a lot about coronary artery disease at all because most patients have had their cardiovascular event, and not that many patients are going on to CABG or coronary artery bypass grafting or percutaneous coronary interventions once they've been diagnosed with heart failure. For patients who have arrhythmias, certain antiarrhythmics can't be used, and I don't think it's advisable to use them if you're not having symptoms. There's certain classes of drugs that we can't use. We don't talk about kidney disease other than what I mentioned, but you should not be using Advil or Motrin because those medications can precipitate both heart failure and worsening kidney function. We recommend universally that patients get the influenza and pneumococcal vaccine. I purposely didn't put COVID down because we don't know if, treating COVID will prevent heart disease, but we have shown that giving the influenza vaccine is beneficial because we have shown that influenza can precipitate heart attacks. But we do advise the COVID vaccine. It's just we don't have the data to say that it'll prevent a cardiovascular event. And then, of course, all patients who have heart failure should have close outpatient surveillance. So this is to just summarize all the comorbidities that we've talked about today in heart failure. We've talked about hypertension, and we talked about the optimal high blood pressure targets. We didn't talk about specific meds other than the 4 pillars for heart failure. We've talked about the importance of diabetes. We did not talk about diabetes management, but we did mention the SGLT2 inhibitors for heart failure, but that is also used to manage diabetes. We mentioned that select patients should have their coronary anatomy fixed if they need it, although we didn't discuss coronary artery disease, and the same goes for valvular disease. We've mentioned several times the importance of anticoagulation in patients with AFib. We talked about IV iron replacement in patients who have iron deficiency with heart failure. I do want to take note here that says patients with heart failure with reduced ejection fractions. I said that Dr. Lewis, who leads the program at MGH and heart failure, did the studies. He's now looking at patients with HFpEF because we actually haven't shown in clinical trials that HFpEF should be treated, although we are treating HFpEF patients with IV iron. So if you're interested, I know you've had a talk on clinical trials. There is a clinical trial ongoing to talk about IV iron repletion in HFpEF. We've mentioned how to control AFib through AV node ablation and just AFib ablation. We didn't talk about CRT, which is a special pacemaker, but I think you have in other talks. And we mentioned the importance of sleep apnea and treating with CPAP. We didn't mention about cancer-related chemotherapies, and I'm going to not mention that, but that is in the guidelines on how to treat, and that really is just with our 4 pillars. So to summarize today's talk, comorbid disease can contribute to the development of heart failure as well as precipitate heart failure. High blood pressure is a silent killer. As patients are asymptomatic, blood pressure monitoring should be part of cardiovascular health. It's important to treat each of the comorbidities, particularly rhythm problems such as AFib, anemia, and sleep disordered breathing. Lifestyle changes can impact quality of life and improve heart failure and associated conditions, particularly with weight loss and fitness. Thank you so much for inviting me to speak. I hoped I kept within my 20-minute allotment.
You did a great job. We actually have a question asking if you can talk a bit about post-transplant comorbidities.
Yes. So, the comorbidities that happen post-transplant, a lot of them are the same comorbidities that you had before transplant. Like if you had high blood pressure before transplant, you likely will after transplant. However, you can also develop high blood pressure from prednisone and from the tacrolimus that you take after transplant. And also now that your heart function's improved, because high blood pressure can be a comorbidity to develop heart failure, but as your heart failure progresses and you reach end-stage heart failure, you often become hypotensive and you have low blood pressure. And then it reappears when you've gotten your heart transplant and your heart function's improved. So it's important, again, to treat your high blood pressure. Cholesterol's also a problem post-transplant. Some patients pre-transplant may not have had high cholesterol, but the medications can induce high cholesterol. You can see that particularly when you take rapamycin and prednisone, because you're gaining weight from prednisone, patients then go on to develop high cholesterol. Sleep disordered breathing is always a problem. If you had it before, you're going to have it after. Some patients think, oh, once I get my heart failure treated, my sleep apnea will go away. That's actually not the case. And it's not just because you're obese that you have sleep apnea. You can be thin as a rail and have sleep apneas. It's, some people just have it. And it's important to treat because sleep apnea, as I already said, has the same comorbidities as heart failure. It can precipitate diabetes, it can precipitate AFib. So it's really important to treat your sleep apnea. Obesity is always a problem, I think, in general, because people, especially with American diet, are always at risk for gaining weight. But the problem post-transplant is the medications want you to eat. A lot of people get the prednisone 50. They just gain weight through their best efforts because they're so hungry from the prednisone. So it's important to continue to treat and watch for obesity. AFib is rare post-transplant, but it can happen. And we're always vigilant for coronary artery disease developing post-transplant because it's not the same as pre-transplant coronary disease, but then the immune responses can trigger something. So you develop something called transplant vasculopathy. And it's a different kind of coronary artery disease that you get, from garden variety, high blood pressure, high cholesterol, diabetes. It's an autoimmune phenomenon that we kind of have to monitor for. Osteopenia or osteoporosis is common. And so all patients should be having a DEXA scan or a bone density every 1 or 2 years to look. And the reason why is because tacrolimus and prednisone can cause osteopenia. So I always tell people, you just really need to be very vigilant about your self-care and your, primary care needs, because we're talking about primary care things. And the last thing that
no, go ahead. I just wanted the gentleman who's had his hand up for a while. I wanted to make sure we got to him too.
Oh, okay. Yeah, I was going to mention the last two things that are really important comorbidities to monitor for after transplant is for cancer, because a large number of patients after transplant are dying from cancer because of their immunosuppression. And skin cancer is very prevalent. So patients should be seeing a dermatologist every year and following with, for their PCP screening.
Yeah, we did have a question in regards to the upper airway stimulation for obstructed sleep apnea implant, if that is an option for people who do have a transplant, a heart transplant.
Yep, that's still an option. I have to be honest, I don't know a lot about it because it's been a struggle. I have 3 patients who have the device. It's been a struggle to get because of insurance. I've had some patients who have looked into it, but they don't want to use it because one of the side effects reportedly is that your tongue can wiggle. And I have a patient who said they don't want their tongue wiggling. So, but certainly, I don't know if you guys have seen the ads on TV, but certainly they look enticing. It's just you push a button and, the tongue moves out of the way and you sleep better. But it is an option. The option, though, is for obstructive sleep apnea. We still don't exactly know how to treat central sleep apnea. That being said, I've told a lot of my patients, even though I know you don't want to treat your sleep apnea because you don't want to wear the CPAP, but you should still go and get tested and find out if your oxygen levels are low, because some people benefit just from having oxygen at night.
Okay, there's a gentleman, Michael O'Brien. He had his hands up. Mike, go ahead and speak. Ask your question.
That was by accident. I'm sorry, I'm on.
All right.
I was on the computer.
Okay.
So your question was how much immunosuppression causes skin cancer? I don't think there's an answer to that. It's not like chemistry where you have put in this much and then you'll get skin cancer or this much. Every patient is individual, right? And so some patients who have, for example, have had Epstein-Barr virus, they're at risk for developing cancer because of lymphomas or leukemias because EBV is considered a risk factor for lymphoma. Certain patients have had to have induction immunosuppression with ATG. And so those patients can be at increased risk for post-transplant lymphoproliferative disorder. But, your option is we don't give you that and then, you'll reject your heart. So it's really a balance. So the first year after transplant is very intensive with your immunosuppression, but we try to wean and taper people after that to try to have them as low immunosuppression as possible to prevent, cancer.
All right, so there's no more open questions. I did want to say thank you so much, Dr. Tsao, for joining us this evening and showing us your lovely slides. It's been a wealth of information, and I really appreciate the time you spent with us today. I'm going to turn it back over to Hamid.
Okay, so thank you. So again, Dr. Tsao, thank you so much. Great informational program. I've attended a lot of webinars, but this actually laid it out, how things happen and why things happen and how they're interrelated. So I greatly appreciate that. I just want to tell the attendees, we have about 15 minutes left. You have access to one of the finest cardiologists in the Boston area. If you have any questions, go ahead and ask them.
I paid him to say that.
You didn't.
And if there's no questions, I know Dr. Tsao's on call, so I'm going to let her go, and we all can have a great night. No more questions?
Oh,
Patrick saying thank you.
Thank you for asking me to speak.
been our pleasure. Thank you again. I hope you enjoy your 15 minutes before you start up again.
No worries. Thank you.
Thank you very much. Everybody have a nice evening.
Thank you very much.
All right. Bye.
Was that okay, Hamid? I felt like I was literally nervous and all over the place.
You did a great job.
Well, thanks. I think you're just saying that, but thank you. And thank you again for asking me to speak.
You know, no good deed goes unpunished, so we're probably going to ask you again.
I was going to say, if I can ever do anything, I'm happy to. And I want to express my gratitude to the HeartBrothers because you have done so much for our patients. You know, several times we've had patients who've been nervous and you've come to talk to them. So thank you so much.
Hold on. Patrick Sullivan raised his hand, so let me view this and let me give it. Patrick, go ahead. You can speak. Pat? Unmute. If you unmute, you can speak.
Dr. Tsao, this is Pat Sullivan. I'm one of the founders of the HeartBrothers here. And
Oh,
I just want to thank you for very, very much for doing this for us. It's always a pleasure. And you did a great job. Don't think otherwise. We
you're
do.
very kind.
And please say hi to Dr. Lewis, D'Alessandro, etc. For me.
I will. And thank you so much for all you've done and the HeartBrothers. I was just telling Hamid, what you do is invaluable to our patients. You know, when you come in and talk to them, it means so much.
We do a lot of grants as well to your
Oh,
patients.
and we can't, the granting that you've given our patients, especially the ones from Maine,
Yeah.
really, we're so grateful. And I know some of them have really pushed for more, but they really are so resource limited that, you know,
Yeah.
our heart aches for them. And a lot of their treatment wouldn't be possible if you weren't there supporting them.
We understand that. We'd like to do a lot more, but it's just with the economy and other things, and it's increased the need for patients' travel and other expenses, and we try to keep up. We try to keep up, but and we are. So far we have, and it's been a very rewarding experience. I can tell you this: 98% of the PARFs we do, patient request forms for financial aid, make under $50,000. So it's just it's a crazy world out there, and we give someone $1,000, and they write me and say, "You've changed my life forever." And it's like, wow, and that's due to people like me and the rest of the team. I think Glenn Rockwood, who's your liaison there, is a great ambassador for us, and we're getting more people to visit your people. We're adding people. We interview them and we add people that we think will be positive and create hope, because sometimes, they can scare them. If someone's waiting for an LVAD workup or a transplant workup, and you went in there, it was like me, and said, "Oh, by the way, I was in the hospital for a year." Now, we never say that. My partner Bob always said, just use the PG version of your story. You're there to listen and bring hope. And that's what we try to do in everything we do.
Well,
But
you're doing it.
Your assistance really helps this.
I have one more raised hand. Howard, go ahead and talk. Unmute yourself.
Hi, I didn't mute. I mean, I didn't raise my hand. I don't know why that happened. I thought am I supposed to still be on this? Actually, am I the only one?
Yeah, you are, and it's okay. You can be on.
Oh, all right. I didn't know. I can just log off. I thought it was interesting to learn more. I'm just newly on the list, and trying to find my way. So thanks.
So Howard, you know, we have, I don't know which center you are, but we have ambassadors for all those centers. If you reach out to your social workers or your transplant coordinators, anything HeartBrothers can do for you.
Yeah, no, you're. I mean, the fact that I'm connected is because I'm already talking to HeartBrothers.
Okay.
Bob Michaels in particular has been really helpful, but a lot of people. I talked to like 8 or 9 of you guys.
Okay.
And so I'm there. I'm out of Tufts, and so there's a lot of changes going on at Tufts.
Yes.
And that I need to figure that out too. But anyway, I'm just here to right now just to learn as much as I can. So thank you.
No problem. Great.
Well, good luck to you, Mr. Pearlstein. I wish you the best.
Thank you. Thank you. Me too.
You'll be fine.
All right.
Thank you.
You will be. You're in good hands, Mr. Pearlstein.
Right. Good. Thanks.
Thank you, gentlemen. Thank you again for all you do, Hamid and Patrick and the rest of the HeartBrothers.
Thank
You're
you.
welcome.
All right. Good night.
Good night.
Bye.
Night,
Bye.